Good afternoon. It is my special pleasure to welcome all of you for the Department of Medicine and Medical Library sponsored Launch and Learn seminar. Today's topic is called Journey to Better Health, CalAIM 101. The Grand Rounds the Launch and Learn seminars functions as Grand Rounds, and we provide CMEs as well as CEUs to those who wish to receive it. To get the CME, I will send you the CME evaluation form. Please return it to me, and I will return the CME certification. For those who wish to receive a CEU, please sign up on Health Learning for this class, and I'll be happy to guide you if you have any questions. The Launch and Learn seminars are, as I mentioned, they function as grand rounds. And today's very exciting topic will be on CalAIM. It is my special pleasure to announce that our guest speakers are Michelle Delacaya, RN, BSN, MFS, and Dr. Edwin Poon. Michelle is a director of Office System Integration and Transformation, Santa Clara Valley Health Systems. Michelle supports transformational work across the health system in collaboration with operational leaders. A nurse by background, her passion is rooted in patient advocacy and in caring for the whole person. Although she misses patient interactions in her day-to-day work, she enjoys helping find solutions to complex problems in support quality care delivery for vulnerable population in all settings. Dr. Edwin Poole is a Director of Managed Care, Behavioral Health Services Department, Santa Clara Valley Health System. Dr. Edwin Poole is responsible for developing and enhancing the department managed care functions in preparations for CalAIM. He leads cross-systems, county, and community collaborations to improve the quality of care for beneficiaries served by BHSD. Dr. Poon earned his PhD in clinical psychology from Michigan State University. He received his postdoctoral trainings at Rancho Los Amigos National Rehabilitation Center and Patton State Hospital. He also completed a leadership fellowship program with the California Healthcare Foundation. Dr. Poon is a licensed psychologist in the state of California and has over 10 years of clinical experience in various settings. Prior to joining the department, he was the director of behavioral health services at CalOptima, a managed care plan in Orange County. Today's presentation will be recorded. We will have Q&A options after our speakers spoke. So please give a very warm welcome to Michelle Delacaya and Dr. Edwin Poon. Michelle, please take it away.
Thank you so much, Judith, for the wonderful presentation. I'm getting a little background. So just a reminder to put your phones on mute. Edwin, thank you so much for joining me in this presentation, and we look forward to talking to you about our journey to better health in the County of Santa Clara and the health system. And in that vein, also talk to you about our work around CalAIM and hopefully answer some burning questions that many people have had to date. If you do have questions, we would love to have them in the chat. We do have some folks monitoring the chat today, so we hope to be able to capture additional questions. If after the fact you have more questions, there will be some sites that you can go to and an email box that Edwin and I coordinate to make sure that we get to the right respondents with our team in HHS administration. I also want to just thank this presentation doesn't come by itself. We've been partnering with a lot of people around this presentation, including folks in behavioral health, custody health, and within the Valley Healthcare system. So we appreciate everybody's input and support in this journey. And I believe we'll also have a couple people from Santa Clara Family Health Plan that might be joining us today, and they may be able to offer some additional information or insight on how to make referrals if those questions come up. I'm going to go ahead and share my screen, and I'm going to do my best to make sure I check all the boxes, including that it includes computer sound, because I will be sharing a video from the state of California. So give me just 1 second, and I'm going to do that. All right, and I would love to see a thumbs up or some sort of reaction. Great, I see Edwin's thumbs up, so perfect. It means that you can see that. As we mentioned, it's really about our journey to better health. So the County of Santa Clara has been on this journey for some time. Many of you may know our vision of better health for all, and this is actually part of the journey to get there. So we like that kind of framework and really want to express how much work we know everybody in the health system does every day to make that real. And what we're trying to do is really link that to some of the services that are now benefits or services in CalAIM, as well as cross-section many of the different initiatives that the state of California has. So, all right, just by way of we need to do this. We do not have any financial endorsement for doing this work or this presentation. I see Edwin nodding, so he's in agreement with that, and that is set. You probably got our flyer that has a little bit of information about what we're going to talk about. We're going to go through some background, a video, some of the initiatives and priorities, and there are a lot. So we're going to spotlight a few of those, including the PATH waiver, justice-involved population, housing and behavioral health. And then we're going to go into a little bit more detail about the new benefit, enhanced care management, as well as some of the community supports and how we work with our managed care plan partners in providing those services, and then how to access those if you have patients or family or community members that you would like to refer to those services. To give you a little bit of background, our journey involved in the last 5 or 6 years, the Whole Person Care Pilot, which was a different DHCS, Department of California Health and Human Services waiver program that was a demonstration pilot. We were one of 22 California counties to participate in that pilot, and our features that we used to pilot in the whole person care mirrored some of those things that are in CalAIM for the vulnerable populations that we as a county health system serve. CalAIM right now is a 1915C waiver over the next 5 years, and the initiatives are across all sections of the health system, including some of those outside of the health system, but county services. And the managed care plans were Santa Clara Family Health Plan and Anthem here in Santa Clara County are the administering those benefits and services through CalAIM. So in whole person care, we managed all those services. In CalAIM, these are being administered through the managed care plans. And then in the future, and what we hope to see along the line with the county and DHCS initiatives, that we'll move towards a full integration model in 2027, which looks at a few different things, including parity, where we have increased equality and justice along mental health and substance use disorder for all populations, not just the Medi-Cal population. We hope to identify increased risks through population health, so getting that stratification of risk and also providing services to all areas. And we want to improve quality of services and drive transformational projects. All right, on our HHS Connect site, if you look at the top corner top right corner, you'll see this little logo, and that is our Journey to Better Health. If you click on that and you're on your intranet for county staff, you'll be linked to this, and you can find out lots of questions, lots of resources that have additional information about CalAIM and different organizations that have information about CalAIM if you want to learn more. There's also a link there if you have a question and you can't remember how to reach one of us. You can go through there and it will get to a general email box, and they can forward the questions back to us. I'm going to show a video, and I'm going to look over to Edwin over here, who's going to give me a thumbs up if he can hear it, because that's one of the big challenges. And this is the California State's description of CalAIM. And I love this video because it really reflects our beliefs and part of our journey as well.
We're transforming Medi-Cal. It's our journey to a healthier California for all. CalAIM is an innovative, long-term commitment to transform and strengthen Medi-Cal, helping people live longer and healthier lives. Through CalAIM, Medi-Cal will be person-centered, equitable, connected. CalAIM will identify people's needs, focusing on preventive care, wellness, helping people with complex health and social needs, all the while putting the person at the center of care. CalAIM will coordinate all Medi-Cal care so people have access to a whole range of health services. Physical health care, behavioral health care, developmental and intellectual disability services, oral health care, long-term services and supports, and ensure care addresses social drivers of health. CalAIM will improve people's lives. CalAIM breaks the mold of the traditional healthcare system. It's much more than a doctor's office or a hospital. It's about providing equitable, coordinated, and person-centered care that gives every Californian enrolled in Medi-Cal the care they need to be and stay healthy. Its success will be a model for transformation of the entire healthcare sector. Learn more at dhcs.ca.gov/CalAIM.
So I hope you could see the similarities in the work that we do here in the county with what DHCS is representing here. We offer a lot of these services, we do a lot of this work, and now we need to build on that and grow for a better health for all in Santa Clara County in alignment with California's effort to make better health across a California journey as well. So to do that is no small feat. So it's not like a flip of the switch. It's not a simple process. And so you'll see listed here 70 initiatives across CalAIM and other DHCS initiatives that we're working with and tracking to make sure that we don't miss a beat and try to maximize the revenue while improving the health care delivery system. Again, this is not a flip of the switch. It's a transformational process, which is why we have so many people interested in this work, so many people driving towards this work because it's the right thing to do, and our community, our system, and everyone in the community will be better if we do this well. I'm not going to go through each one of these, and the next two slides you're going to see equally as confusing because they're these 70 different initiatives over the timeline of 2 years or 7 or 5 years, depending on which grouping we're talking about. You will see, however, on this slide, we have some buckets. So we have behavioral health, justice involved, homelessness and housing, some Medi-Cal restructuring, the home and community-based services, initiatives addressing children and youth. The whole benefit system of Medi-Cal is being looked at, and there's integrated health work that's aligning some of this work with national standards and measures. This is the timeline. Again, I don't expect you to memorize this or see it and go, oh, I know exactly what that is. These are several of the CalAIM initiatives that go from currently in 2022 through 2027, where there will be full integration pilots and a lot of other components that kind of come together to bring that picture that California has for CalAIM. There are several other DHCS initiatives that are not specific to CalAIM, but we're watching and we think align really well with this journey towards better health and hitting all the needs of our community. So these are other initiatives that we're watching and we think align really nicely with our journey to better health. So funding. We are seeking a lot of funding streams through this, and there are several here. We have something called Providing Access and Transforming Health, which is also known as PATH. Some of you may have heard about PATH. There are actually 4 paths to PATH, and so we are tracking all 4 of these paths. One is called mitigation. That is, and I'll talk a little bit more about this later, so I'm not going to go into it here, but that we are tracking all 4 paths to PATH, and we will be following that. We are doing service provision as the county. We are a provider for enhanced care management, which is a new benefit for populations of focus in the Medi-Cal managed care population. And we are also working on new services and called community supports, and we'll go into a lot more detail on those too. Edwin is going to talk about Behavioral Health Quality Improvement Program, or BHQIP. And then we're also in partnership with our managed care plans through an incentive payment program called IPP, and that's to help us develop infrastructure to deliver the services that are needed to achieve CalAIM. So PATH, a little bit more here. Again, this is funding to bridge from whole person care to CalAIM, and including those enhanced care management and community supports. This funding is waiver funding available to counties, cities, and other community providers. And this particular funding stream is not eligible for the managed care plans to apply for. However, we do involve them and make sure they know what we're applying for so it doesn't conflict with other funding streams that come in. I told you there are 4 paths to PATH. The first path on PATH is mitigation, and that's where whole person care counties or former lead entities can apply for fundings for services that were provided through whole person care that are part of CalAIM but weren't initiated yet. And we did apply for and were approved for 6 months of support funding for our sobering station and for our medical respite program. The next path on PATH is capacity and infrastructure transition, expansion and development, otherwise known as sited. There are 6 rounds to sited funding. We have applied for our first round as the County of Santa Clara, and we are pending results of that first round, and we anticipate participating in this waiver for the next 5 rounds. There's a regional collaborative and planning and implementation path on PATH, and we as the County of Santa Clara are participating in that, and we have encouraged our managed care partners to participate as well, and we look forward to looking across our region to see how we can leverage some of those key infrastructure components that we might need. There's also a justice involved capacity building. There are 2 rounds of funding for that, and I'll go into a little bit more detail on that right here. So in our current state, in our justice involved, we have, there's a justice involved package, which is one of the initiatives of CalAIM that is currently in ongoing negotiations between the state and the federal government in regards to what that will look like and what will be implemented in that agreement. And I'll talk about that in the forecasted change part. Right now in the current state, we have a subset of Medi-Cal applications that are done for anybody in our justice system that's county run, so our jails or juvenile system, and that's done 60 days pre-release. And then all services that are behavioral, medical, or dental that are provided in the jail system now are covered by custody health. I talked a little bit about PATH. We have round 1 of funding that we applied for and did get awarded, and that is to plan for development of Medi-Cal enrollment. Round 2, which is due for requests the funding request is due in the end of this calendar year, is to implement that plan that's developed in round 1. And we're in the process of doing that. What we're anticipating is that this work is going to focus around ensuring that all eligible adults and juveniles in custody will have support in 90 days prior to release, and that would include Medi-Cal applications and a subset of Medi-Cal services that they may be eligible for during that time frame. Edwin, I'm going to hand it over to you for the next couple of slides. Thank you so much.
Thank you, Michelle. So you hear me okay?
Yes.
Great, thank you. All right, so the next couple of slides highlight the behavioral health components of CalAIM. So before I go into the details, I want to first really share to make sure that everybody kind of understand the structure of behavioral health within the Medi-Cal benefits. As some of you may know, behavioral health services coverage is actually bifurcated within Medi-Cal. We have the non-specialty mental health services, formerly known as mild to moderate, is actually a benefit, mental health services and benefit provided under the managed care plan. And while specialty mental health services and drug Medi-Cal, which is, addiction treatment, are actually carved out from the managed care plan. So in essence, county behavioral health is actually a managed care model specifically for specialty mental health and drug Medi-Cal services. So with that in mind, what CalAIM have set up to do for behavioral health is really trying to ensure that our Medi-Cal beneficiaries have access to services and that there are really strong care coordination between the two systems. So you can think about these county behavioral health components under CalAIM in 4 areas. The first one has to do with access. So the state under CalAIM has updated medical necessity criteria, for example, to make it easier for people to access care. Also, they created a new policy called No Wrong Door, which really meant for, again, people not that they're not going to be bounced around between the two systems that I've just described, the bifurcated system. And then there will be a very exciting and universal screening and transition of care tools that both the managed care plan as well as county behavioral health will be able to utilize so that we can coordinate those services as the clients and the beneficiaries, their needs changes. In terms of documentation, one of the things that we as county behavioral health have really informed DHCS a lot about some of the challenges that involved in the documentations and the notations and all these paperwork that we have to do. And one of the things that the state really listens and understands is that standardizing assessment, treatment plans, and changing that from treatment plan to problem list, and also streamlining the progress notes, really important for our system to really thrive and to make sure that we dedicate our time to really treat the client, not necessarily focusing so much on paperwork. So it is really actually very exciting changes. So even though it seems like it is more of an administrative, but it will translate to better care. The financial and the kind of benefit piece of it include some technical details, seemingly more administrative, but it also does have an implication of how we really monitor our systems and how to coordinate care. I just wanted to highlight, for example, a CPT coding. Many of you probably know what I'm talking about when I say CPT code. County behavioral health historically use a set of codes that are very unique to county behavioral health, and often it's not easy to translate to what those services really mean. So when you try to compare information and share information, other systems may not really understood or recognize what services are being provided within the county system. So one of the really fundamental change here is to allow us to really align these services and benefits. So even though they are provided in two systems, managed care and county behavioral health, there's going to be a much easier way for us to really communicate and share their care information. And then last but not least is the infrastructure development, which include administrative alignment. As some of you know, we used to here at county, we used to have 2 departments, a mental health department and a substance services department, and we have integrated in anticipation that the state actually recognized that that is also important, these type of alignment. So we're very excited about that. All right, Michelle, if you can move to the next slide. So Michelle alluded to the BHQIP a little earlier under the funding sections that she presented. And this is the full name is Behavioral Health Quality Improvement Program. It is, we consider that this as an infrastructure improvements. It's because it's actually a state program that we're working directly with the HCS to receive their approval for our implementation plan. The implementation plan contains 3 areas: payment reform, policy changes, and data exchange. Let me just kind of highlight a little bit of each of the component. Payment reform is it's a structure of alignment of funding sources. So behavioral health, county behavioral health funding is very complex. It involved a multi-year sort of cost settlement process, which not just cumbersome, but really made essentially kind of our system is not very flexible because of those payment structures. So the essence of payment reform is going to allow the county to utilize various different payment methodology with our providers, including incentive payment, including value-based payment. These are really exciting time when we talked about looking at quality outcome. We want to drive quality improvement, and those are some of the tools that are going to be available to behavioral health in our relationship with our providers to ensure and to improve the quality of services. So very exciting indeed. The second area is policy changes. So with all of these new changes in terms of medical necessities, no wrong door that I've just kind of alluded to, there are a lot of steps that we have to take to make sure that these policy changes are implemented, not just from a delivery perspective, but also structurally. So we're looking at a lot of these improvement, documentation, manual, audits, tools, and all those things has to be aligned. So there's a lot of effort going on right now with the departments to do that. And then last but not least is data exchange. This may be one area that many of you are interested in because, you know, we have the health system here within the county, but we also have behavioral health. Many of you know that we do have 2 different EHR, but we are working really hard to look at opportunities to really cross those 2 platforms and how we, for example, really create a ability for us to really share information and communicate so that you're treating a client in the physical health space, yet we'll have the opportunity to understand what behavioral health services that this client, your patient may be receiving, and vice versa. And also communication between, again, the county behavioral health and our managed care plan partners, family health plan, Anthem. So those are really fundamental shift and infrastructure that we think CalAIM will provide us with that opportunity to really, again, deliver that person-centered care. Michelle, I think this is my last slide. I'm going to hand it back to you.
Thank you so much, Edwin. And, you know, just one of the side benefits is that Edwin and I get to partner a lot on a lot of these projects because they do have a lot of overlap. And so really that data exchange and the infrastructure, trying to make sure that we align on that and make sure that we're doing things that are future driven, not just at the color of the day. So thanks, Edwin. I don't know if anybody from the Office of Supportive Housing is on the line, but they may be more familiar with HHIP than I am, but we are watching HHIP, and again, another opportunity for us in the health system to really partner with our other county partners and other county departments, and that is with HHIP. This is the state engaging with the managed care plans and doing and investing state dollars to the managed care plans to put a focus on homelessness and keeping individuals housed and using and encouraging them to use the partnership with our agencies and the continuum of care and the local homelessness plans, so that it's not recreating the wheel, it's actually leaning in and working with our local agencies around prevention, interim housing, rapid rehousing, and permanent supportive housing. So there's a lot of activity around this, but it's definitely something that we're watching and partnering with. One of the key components of HHIP that we are involved in is the street medicine components and some of the data sharing around that. All right, enhanced care management. This is one of the hallmark pieces of what whole person care and CalAIM really learned, or what CalAIM is showing that we learned from the whole person care initiative and the whole person care demonstration process across the state of California. ECM, Enhanced Care Management, is now a benefit available to eligible Medi-Cal members. And that is really saying something for the work that the state did in the whole person care pilot to show that these wraparound services, face-to-face, and high touch case management or care coordination services are really beneficial to the most vulnerable populations that we serve. It is a benefit. It should be available to eligible members at no cost, and it will not take away any of the other benefits of Medi-Cal. It addresses social drivers of health in addition to looking at behavioral, oral, and physical health and any other needs that may be in that person's realm. Right now, ECM for the County of Santa Clara is provided. We are a provider of ECM services, and we are currently contracted with Santa Clara County, Santa Clara Family Health Plan, FHP, to provide services as a provider to those folks that are sent to us or that we request that get approved for enhanced care management. We have touched over 1,000 people year to date in this program, and we are successfully billing and cycling through the billing and invoicing process for this service with the county as a provider. We are going to be doing a pilot with behavioral health, and we're really excited about that, and the collaborative courts, and we anticipate that will be starting next month. Currently, a Medi-Cal managed care member who is in the population of focus that is live now, that would be adults or families experiencing homelessness, high utilization, or serious mental illness or substance use disorder, are eligible for ECM. In the future, as soon as January of this next year, these individuals at risk for institutionalization, adult skilled nursing to community or to RCFE would be eligible. And then there's some children and youth that will also be eligible in the next year or two. Enhanced care management includes all of these components. Here in Santa Clara County, we use a program called CCSP, or Care Coordination Services and Programs, and that's adapted from much of the learnings we had locally in whole person care, and then shifting that to adapt to the needs and requirements in enhanced care management to meet those needs for contractual agreement, also for billing and revenue collection. We are really trying to make it seamless for our frontline staff to be able to enroll people that they believe need that service independent of payer. And then on the back end, we try to pull out and generate the revenue that might come from the enrollment in one of the managed care plans. We also are developing more seamless and streamlined processes to refer to other care management programs that that person may be eligible for in other systems. Community supports is the next, our services that are approved and reimbursable by the managed care plan for those that may be eligible for them. There are 14 approved community supports, and there's a staggered release of those based on the managed care plan and the county in which they are they exist. They are intended to avoid more costly levels of care like a hospital visit or a skilled nursing stay, emergency department visits, or other things that are more costly. So they're used to be called in lieu of services. So things that happen in lieu of hospitalization or higher cost services. They must be considered medically appropriate for that reimbursement to happen, and they have to be approved by the managed care plan, again, for that reimbursement. Another sorry yet confusing slide with lots of information, but we want you to have access to this so that you know what those services are. These are the 14 services that are approved by the state of California as community supports, meaning the health managed care plans can opt into providing these services. You'll see here that in our county of Santa Clara, we are lucky to have 2 managed care plans that are interested in providing all of these services to eligible members by, I think the last one is going live in July of 2023. So all of these services will be available for Medi-Cal managed care plan members in Santa Clara County that are eligible. And the process for referral, et cetera, is I'll talk a little bit about later, but we're also trying to develop an internal process for county staff to refer internally so that, again, we can decrease that need to decipher on the front end and hopefully get it to the right place on the back end and get them approved for services. You'll see here that we are a vendor for 4 of these services, almost. We have been a vendor with Santa Clara Family Health Plan for housing transition and navigation since I think we started those services in May and June, and they did backdate until January. And we are working on finalizing contracts for the housing tenancy and sustaining, sobering, and recuperative care with Santa Clara Family Health Plan. And with Anthem, we have not yet signed the contract, but we are in negotiations for that as well for those 4 services. We are partnering again with the Office of Supportive Housing, who's doing the housing transition and navigation, and they're going to be, we're developing the workflows and the data capture and the exchange for tenancy now. You may know that we have in the past we already had a medical respite program that was actually approved through Whole Person Care, and we're working on developing that workflow for providing that in the with Santa Clara Family Health Plan and the Community Supports Program. And you also may be aware of the Mission Street Recovery Station that was developed as a sobering center during Whole Person Care that we're providing services ongoing. And we are working with our partners to get reimbursed for those services when a Medi-Cal managed care or when an eligible Medi-Cal member receives services there. Okay. So I feel a little bit out of breath, and I think we're going to have some time for questions, and I hope that we have some. There may be some folks on from Santa Clara Family Health Plan for additional information on referral process there. This page here, there's really 2 ways that members can access these services of enhanced care management and community supports. One is that a health or social service provider, a behavioral health provider can refer somebody, submit a referral for either ECM or any of the available community supports. And there's a link on this when you, I think we'll send this out, the link for Santa Clara Family Health Plan. They have, that's a link for the page that has all of their available community supports with the referral forms. And then Anthem has one referral form for all of the community supports. The other option is that a member or a family member of the member can submit a referral to the managed care plan on the member's behalf, and they can contact their Medi-Cal plan by using the number on the back of their insurance cards. There's some additional numbers here for Santa Clara Family Health Plan, specific for community supports and specific for ECM. And then if they're ECM eligible, they will get a provider or vendor for those support services. Our team is working, like I mentioned, on kind of a referral hub model so that we make sure that anybody that the county is servicing is, we are trying to streamline that process because some of the information is difficult to get. So we're working on some streamlined processes for that through a PDSA cycle. Okay, with that, we have questions. I would like to stop sharing so that if anybody would like to raise their hand, then we can see you. You can also just pop on video or put your question in the chat. That would be awesome. We've got quite a few people on here, so I'm hopeful that we have at least one question, right, Edwin?
Yes, don't be shy.
Also, feel free to send your reactions in the chat if you'd like. That's always helpful.
I guess I went too fast, Edwin.
It is a lot of, oh, wait, can,
Oh, yes, yes. Laura, can a medical social worker submit a referral? Absolutely. So anybody who's a provider for an individual can submit a referral for services. Laura, are you working at one of our health system hospitals or clinics? If that's the case, we can, great, at VSC. Absolutely, Laura. There is actually a current way you can do that, sending in an inbox and connect with myself or with Chris Dodson, and we'll be able to get you that information. Great.
Question from Jennifer.
Great. Is somebody able to read that? I just lost my chat there.
Sure.
Jennifer.
Sure. So Jennifer's question, Michelle, is that she said you mentioned criteria for community supports. Has that been developed?
Yeah, thank you. So community supports, there are specific criteria that's available, and you can look at the DHCS website. I think I have a binder about this thick full of information about the community supports. In addition, you can look at the Santa Clara Family Health Plan website or on the Anthem website, and they do have some of that criteria listed. If you have a specific community support you'd like to know more about, you can put it in the chat, or you can go to the HHS Connect website and send an email, and we'll try and figure that out for you.
Okay, I'm going to try to read off the next question to you, Michelle.
Sure.
The next one I see is from Michelle, and the question is, are there benefits that will support the perinatal population under CalAIM?
Great. So anybody that I'll have to look at that a little bit differently. I think if they're experiencing homelessness, high utilizers, SMI or SUD, there's potential that person would be eligible for services now. The children, if the children are experiencing homelessness, that's a population, children, a family that's experiencing homelessness, that's somebody that we can help now in the ECM process. I like to say, you know, we have lots of services in the county and the county organization. So if there's somebody in particular that you need help with, we can try and work with you, Michelle, directly. I know that that's definitely a population at uber risk, and we want to make sure that they have the resources that they need. And so eligibility for ECM may not be the only way for them to get it. So if you've got some specific questions, we can reach out to you specifically about the population that you serve.
Okay, next question is from Christopher. He asked, how do these new wraparound services intersect with AOT, which for those who don't know is assisted outpatient treatment, and with the ACT programs? Can an AOT person be automatically enrolled into, I assume that you meant probably ECM or housing help?
So, Christopher, that is an excellent question, and one that I'm going to do my best to answer, and we may need to work, Edwin, on just clarifying around that. So ECM can be layered on top of additional services or needs to be apart from other services. So for the most part, you can have it layered on top, and I will have to look specifically at the AOT or ACT program to see if that falls into any of the exclusions. But absolutely, what my hope is that we develop systems where we can provide the layers of support to help the person stay safe and healthy in the community to maintain optimal health. And then once they're kind of a little bit more stabilized, we can peel off one level of support and then another level of support until they're able to be successful with the minimal necessary support in place. One of the challenges is making sure that the person at the center of the care has clarity around who's going to be their point of contact. And that's one of the things that's really important as we go deeper into this service provision, that patients, vulnerable people don't tend to want 10 people calling them about 10 different things that if we could coordinate better, one person could do. So those are some of the challenges and why it's not a flip of the switch, but it's definitely something worth digging into.
Thanks,
Are you
Michelle.
going to take?
Lorena is the next one. Lorena Madrid.
Is she on the chat or?
She's on the chat.
Okay,
Oh,
we have
okay.
Matt Osmet. Do you want to take Matt Osmet?
Judith, we're going down the list
Sure.
here.
Please do.
Yeah, so I think next is Matt. It says me, Edwin. Data sharing from my avatar to MCP, does that include VMC and Epic? Short answer is yes. I think we definitely have been really started the conversation with our counterpart over at VMC, Epic, looking at how do we really bridge that connection between the Epic system as the My Avatar. Particularly, we're looking for a module called Care Quality, which potentially will give us that kind of a bridge of communication, of data exchange. So I think we should all be excited about, and certainly there are some hurdles from both technical standpoint and also compliance and regulatory, but we think we can overcome those. I think there's a lot of interest, and I think it's necessary for us to be able to truly serve our clients on both sides. So, yes, stay tuned.
Yes, great. I see the next one here, Edwin, and it says, how can a student be supported in getting services if they live in Santa Clara County, but are in San Francisco for college? Beatriz, I don't have an answer for you, but I do know that the service provision would be under the county where their Medi-Cal is living. So if they're a Santa Clara County Medi-Cal member, likely they would need to connect with their managed care plan to figure out if they can get those services locally. Because if they are living and receiving care in San Francisco, that is, we found, at least in whole person care, that having that care coordinator or that lead care manager as close to the primary care or behavioral health medical home is key to get them interventional and the support they need wrapped around them to be successful and getting optimum health. But excellent question. I would go directly to the managed care plan that manages their Medi-Cal. Vicki, you're welcome. This is great. There are incredible services here, and it is bigger than a bread box, but we're doing our best here. Lorena, interested in client level data on social support and how that will be captured and shared, capture population. Oh, Lorena, we're going to watch that spot. There's a lot of information, and if you look through the DHCS website, there's a whole population health journey as well, and that is increasing some of the responsibility on the managed care plan as well. A lot of that data sharing is going to be really complex and needed, again, because we want to streamline that process of getting the population health data and making sure that we share that information so the health plan has it, that the provider has it, that everybody who needs it has it, and we're not all calling one person for one measure that might be on a population health dashboard. But a lot more to come on that, Lorena. Reach out if you want me to connect you to again, another packet about this thick for the DHCS plan on population health management. Okay. Oh, Edwin, do you want to take the 42 CFR or you want me?
Yes,
Kimberly.
I will take it. So, unfortunately, the dreaded 42 CFR continue to, of course, exist. I think the federal government have more recently tried to kind of interpret it with a little bit of clarity, but the reality is that while the state recognized that that's important because it is a federal regulation, so there's not really a lot that we can do to circumvent it. But one of the things that I think is really important for us to think about again is consent, because if there, I strongly believe that we need to engage with our clients, the patient, the clients that we service, to talk about the importance of really looking at all the various cares that the person is receiving, the whole, again, the person-centered approach, the whole person care model. And I think if we are able to really connect with our clients and talk about and with them about the various different service and needs, then and gain that consent, then we can still, I think, achieve a more coordinated care, even though we may not have that sort of ability to just share information without the consent level. So I just wanted to, I always like to remind people that there is something that we can do, again, is to really engage our client, the people that we serve, and really talk about all their healthcare needs, including physical, behavioral health, mental health, and substance use.
Thank you, Edwin. Just in case you're wondering, there is some additional information. Thank you, Amy. Thank you, Chris, for putting in some additional information. And Chris mentioned that he'll send out some of the how to do an in-basket message to get somebody referred for ECM if you're on HealthLink. I'm going to go to Candace's question, and this individuals with dementia and behavioral disturbance eligible for behavioral health services while residing at a SNF. I think we might need to do a little bit more digging into exactly what you need, Candace, but I think there's definitely these folks are at risk already. That long-term care and the behavioral health kind of co-occurring illnesses are significantly complicated. And then the CalAIM Medi-Cal management as well is one of those that is actually excluded. So if they're on CalAIM Medi-Cal and ECM services cannot be delivered at the same time. So we can connect them with the CalAIM Medi-Cal, and we also have some folks that will actually help when we can. We have just a few people, so hopefully we can help with some of those folks. But we do understand that those are a very complicated subset of folks, and there's work in the initiatives around the LTSS work. And so we can look into that and try and send you some of that information about where the state is going with the LTSS. It may also be that we need to connect with the managed care plan that's serving that member. It looks like is it Dr. Murphy or Elizabeth Murphy from VHP?
Dr. Murphy. Yeah.
Dr. Murphy, yes, we will work with you on making sure that VHP has the same information, and we our ties are a little closer there, so we'll do our best to make sure that we meet those needs for sure. So we'll be in touch on that. And Edwin, I think that might have been directed towards behavioral health data, so we want to make sure that we're collecting that and making sure we have clarity around that and make sure that we're able to do that. It does cause some challenges with compliance and those things, but those are things that we can overcome with our can-do and partnership attitude. All right.
Yep.
Length of service and process upon discharge from respite care. Annette, that is a great question. The community supports is 90 days of medical respite. Our current program has a little bit more flexibility. So if you have a specific person that you're looking to refer, you can reach out to our team and we can try and answer those questions. It is a very difficult time if you've got somebody in medical respite and then a discharge plan from there where there's not always a safe discharge plan. So it kind of pushes for lack of a better way, kicking the can down the road to make sure that we have a safe discharge plan. We know that's a big risk. So we do our best in that situation, and you know, again, have some resources available, and they do partner very closely with our supportive housing team. Okay, I'm noticing we've got 5 minutes left, and we got more than one question. So Edwin, I think we're good. Preventative care QIP measures. I think so, Michelle. I hope so. You know, we do, our ECM providers do watch care gaps and try to close those as well. So hopefully that will improve QIP measures as a result of that. So when they're talking to them, they'll encourage them to do those care gap closures. But the scope of this is, again, about 8 to 10% the state believes is going to fall into this category, and they are difficult to reach and sometimes not using their primary care resources as we would like them to. So they might be an at-risk population for this work in general. So although we are looking at those and those population health measures, sometimes the specific population that we're working with on ECM may not see that, but we'll be working with them as well.
The next one is pretty straightforward. Again, the answer is yes, and care quality, again, is sort of the module that we're looking at to bridge the gap between Epic and Avatar. So again, stay tuned.
And thank you again, Chris, for adding some more stuff. Lorena, we are working on a care coordination guide. You're probably asking that question because there's so many different care coordinators and so many different programs, and that's making it confusing, but it is on our radar, and we do believe it's valuable and important to consider. So reach out if you want to join our team or our efforts to do that, because we know there's a lot of different things going on. Yeah, CCS, Rami, when we look at the California Children's Services and the ECM, the state has not quite figured that out yet either. So we're really hopeful that we'll get some clarity around that as they start to roll out those programs. But we see that also as a area to definitely keep our eyes out. So let's partner if you've got eyes on that too. Certainly, I see you nodding. So awesome. We got the thumbs up. Perfect. We do see that as a potential risk area. Okay, and Chris has got a ton of more information.
I think
oh my gosh. I'm in shock.
We managed to get through.
Oh, so Judith, thank you so much for the opportunity. Edwin, thank you so much for partnering. Special shout out to Chris and Amelia and Jabu and everybody on my team there. Also from Custody Health, everybody in Custody Health that helps us manage and as we go through this, for Gabby and Sherry on the behavioral health team for partnering with us and getting this rolled out, for Santa Clara Family Health Plan and Anthem partners who've been patient with us as we try and figure out how to make these transitions. We're so grateful to all of our partners in this. This takes a village and a half, not just a village. So please, thank you all so much for your time and interest in this really important work.
And thank you, Michelle, for your leadership.
Thank you, both of you. It has been
get a glass of water.
Thank you so much. It was a wonderful presentation. And I want to say that if you wish to get a CME or CEU, please send an email directly to me. Michelle, would you allow us to send out the PowerPoint presentation to those who are interested, or would you like to do that?
If I can just get one more eyeball set on it, make sure that there's nothing too funky, since the last one I had the wrong copyright year and the wrong name on something. I want to just get eyes on it, so because I saw there were a lot of people here, so I think it should be fine.
Thank you very much.
Yeah.
All right.
Right.
Very much. Thanks again. Have a wonderful afternoon, and see you at the next Lunch and Learn seminar on November 16.
Bye, everyone.
Thank you.
Bye.
Bye, everyone.